Hi, it's Dr. Ronald Lett. I'm going to present the traumatic brain injury lecture from our trauma team training course. The three body cavities, the skull, the chest, and the abdomen, are where trauma patients suffer injury and proceed to die. So these are top priorities. Traumatic brain injury. It's defined as trauma to the head with some injury to the brain, with or without altered level of consciousness. Traumatic brain injury, in its relationship to the initial assessment, is under disability, neurological status. However, if you have a patient that's unconscious, their airway can be compromised or they may not be breathing and having proper breathing effort. So it's very important. Traumatic brain injury. Trauma to the head associated with some degree of injury to the brain. It must be diagnosed early. 50% of blunt injury deaths are associated with head injury. The mortality doubles if the airway or the breathing deficit results in hypoxia. The mortality doubles if the patient is in shock. Traumatic brain injury, the diagnosis is made by noting changes in the level of consciousness. TBI mortality doubles if hypoxia results from airway or breathing deficits. It also doubles if the patient is in shock. The critical management of TBI is the ABCs of trauma. The major goal of treatment of TBI is preventing secondary injury due to hypoxia, hypotension, hypoglycemia, seizures, and electrolyte disturbance. The AVPU system is very useful in assessing head injury, and it's a simplified assessment of level of consciousness. A is alert. Only minor head injury is possible. V is vocal. That means they only respond to commands. This is a moderate head injury. P is pain. They only respond when they're given painful stimulus. This is a severe head injury. And unresponsive is a very severe head injury. Classification of TBI. There are many classifications. One is high versus low velocity. Road traffic accidents, falls from a height, or assault will be high velocity injuries. Penetrating versus blunt. Penetrating including gunshot wounds and missiles. Skull fractures can be depressed or non-depressed, open or closed, with or without a cerebrospinal fluid leak. Their locations can be on the vault, across the midline, or basilar. In that case, an NG tube has a relative contraindication. Classification of brain injuries. Focal, they can be epidural, subdural, or intracerebral hematomas. There can be diffuse injury with concussion or diffuse axonal injury. CT scan is the most important diagnostic modality in head injury. We use CT scan without contrast. It's ideal to have it interpreted by a radiologist, but in emergency cases where there's no radiologist, surgeons or residents should be able to identify significant findings. An indication for CT in head injury includes significant injury or mechanisms, like road traffic accidents where many people died, a history of loss of consciousness, seizures, bleeding through the ears or nostril, weakness, severe progressive headache. Intercranial hematoma location. Here we see epidural. There was loss of consciousness followed by improvement. paralysis on the opposite side, a large fixated dilated pupil on the same side. So here you can see the epidural hematoma. The subdural hematoma. Classically, this is for the older patient, but when we're discussing this in the older patient with a venous tear, this is the chronic subdural, as opposed to the acute subdural where there is direct head trauma. The CT scan will show blood covering the brain. The management is surgery if decreased level of consciousness occurs. Other hemorrhages. Subarachnoid hemorrhage. Intraparenchymal hemorrhage. Intraventricular hemorrhage. What is the history of traumatic brain injury? What was the mechanism? Road traffic crash, fall, assault, gunshot. How recently was this injury? Is there a history of alcohol intoxication? Alcohol intoxication can be a cause of the traumatic brain injury. It also can mask how serious the traumatic brain injury is or isn't. Was there a loss of consciousness, and what was its duration? Any loss of consciousness should be taken seriously. Is there bleeding from the ear? This indicates a basal skull fracture, and this is often associated with underlying brain injury. Convulsions may be an indication of brain damage. You certainly should avoid hypoxia, and you should control the convulsions with medication. Signs of increasing cranial pressure, intracranial pressure, weakness of the extremities, dilated and non-reactive pupils. This requires referral for intervention. History. You use your ample history. You need to know about allergies. Medications and drugs that would alter the mental status. Past history, in particular diabetes and epilepsy. The last meal and alcohol. And the events leading to the injury, loss of consciousness, including the lucid interval when they wake up and then become unconscious again, or immediate unconsciousness. Examining the pupil. You look at the size. Is it constricted? There may be drugs involved. Is it normal? Is it dilated? How do the pupils look relative to each other? Are they smaller than each other? Are they equal, or is one larger? Are they responsive to light? If so, is it very reactive, sluggish, or not responsive at all? Anischorea is when there's a difference in size of the pupils. A unilateral dilated pupil indicates a problem on that side. What causes head injuries? Road traffic injuries, bullets, falls, assaults, animal injuries. There can be direct injury to the head, or acceleration-deceleration injury when a person's motion is suddenly stopped, or the head is struck by a moving object. When you have decreased level of consciousness, asymmetry of pupils, and weakness on one side versus another, you have to think about an expanding mass lesion or a hematoma in the case of trauma. If there's associated airway or breathing deficit, or the patient is unconscious with a Glasgow Coma Scale less than 8, or they're only responding vocally, early intubation is required. If the patient is shocked, treat the hypotension, looking for other injuries and manage them. Traumatic brain injury is not responsible for the hypotension. The status of a patient with traumatic injury can be changed rapidly. It is important to repeatedly record the assessment of the level of consciousness, AVPU or GCS, pupillary response, and vital signs. Key points. Perform primary survey. Look beyond obvious head injury for causes of shock. Assess baseline neurological status. Remember, head injury is usually not the source of shock. Reevaluate a patient who deteriorates. In convulsions, use an anticonvulsant and beware of oversedation. A head-injured patient requires first and foremost good arterial perfusion and good cerebral oxygenation. Transfer for definitive care when required.